So hello, good morning, good afternoon and good evening to all our speakers, chairs and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Professor Giorgio Palandri. Prof. Palandri is a consultant neurosurgeon, IRCCS Institute of Neurological Sciences of Bologna, Ballaria Hospital via Alturo, Bologna, Italy. He was a previously visiting clinician at the Mayo Clinic, Rochester, USA, and also the consultant neurosurgeon at the Imola City Hospital in Imola. His clinical expertise is focused upon the management of hydrocephalus and endoscopic surgeries, and he's an invited faculty to various conferences and workshops around the world. We're extremely honored to have him today at webinars, and today he'll be talking about adult hydrocephalus beyond the surface. The speaker for the second session of today is our honored guest from China, Professor Chuan Chen. Professor Chen is an associate professor in the Department of Neurosurgery at the third affiliated hospital of Sun Yat-sen University, Guangzhou, Guangdong, China. He is also the vice president of the Chaozhou Central Hospital and academic leader of the Department of Neurosurgery at the Yudeng Hospital, the third affiliated hospital of Sun Yat-sen University. He heads the cerebrovascular disease group of the Department of Neurosurgery at his hospital, and he is also the vice chairman of the youth committee of neurosurgery branch of the Guangdong Medical Association. We are extremely honored to have him today at our webinars, and today he'll be talking about trapping with bypass for complex ICA aneurysm. The chair for the first session of today is our honorable faculty from Germany, Professor Uwe Keller. Prof. Keller is a professor and head of Department of Neurocenter, Spine Center in Asklepios Clinicum, Altona. He is also the president of the Hydrocephalus Society, and as a specialist neurosurgeon, Prof. Keller, together with his team, is an expert in the management of cerebral tumors, hydrocephalus, trigeminal neuralgia, brain injuries, and cerebral hemorrhages. He is an invited faculty to various national and international congresses around the world. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session for today's webinar is our honorable guest from Japan, Professor Hitoshi Fukuda. Prof. Fukuda is an associate professor in the Department of Neurosurgery at the Kochi University Hospital, Kochi, Japan. He was a previous fellow at the Weill Cornell Medical College, Culbis Laboratory, New York, and he is a hybrid trained neurosurgeon, and his research interests focus upon stroke and cerebrovascular diseases. He was the recipient of the European Stroke Research Foundation Awards in Athens in 2018. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and our wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia and Dr. Ben from Hong Kong and Dr. Joey Sam from Malaysia are my co-hosts for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Uwe Keller.
Yes, thank you very much for this nice introduction, and I'm very happy that we have now a real leading expert of the world talking about hydrocephalus, and Dr. Giorgio Palandri, he is now the president-elect of the Hydrocephalus Society, and I'm sure he will give us an intriguing, exciting lecture about hydrocephalus. Please, Giorgio Palandri.
Thank you very much. Thank you very much to the ACNS for inviting me, and thank you very much, Uwe, for your kind words. So I decided to name my talk Beyond the Surface, and I want to thank you again very much. I feel honored to be here in front of you, and I want to extend your welcome by the ENS CSF section and by the Hydrocephalus Society. I have this conflict of interest. This is Bologna, where I live and work. This is the coat of arms of my hospital, which used to be in the past a villa. And you can see here the old entrance. It was supposed to be completely independent, and you see the chimney, the smoking chimney here at the bottom. And this is nowadays a picture of the old entrance of the hospital, and we'll come to this statue in the end. I will show them to you in a little detail. And this is the new building just in front of the old entrance where I actually work. So I think that here you can see some stars in a blue sky. And here are two telescopes. The oldest one is the newest one, sorry, is the Webb, and the OBS was the old one. And you can see here a picture taken by the oldest telescope, which was raised, I think, in 2002, something like that. And you can see that the new picture by the Webb telescope is now, I think, very similar to the previous one, but maybe we can find more details here. But what would happen if I told you that this picture is taken in a black spot of the old telescope? I think this could make really some difference. In the early 30s, Professor Zwicky found out that the universe was accelerating expansion. This was a problem for the Big Bang theory. And then we discovered that there are really many things we don't know about the universe. For example, that all we see with our very powerful telescopes and new telescopes is only the 5%, and dark energy and dark matter account for the vast majority, and we cannot see them. I think that in some ways this is happening at the same level with the Hydrocephalus. There are many things we don't know. There are many things we don't see, and we should really go beyond the surface. Even the definition and the classification of Hydrocephalus can be very controversial, and we could try to define Hydrocephalus as a state of excessive intracranial accumulation of CSF that results from production, circulation, or absorption of CSF. And if you go to Wikipedia, for example, no page for acute hydrocephalus does not even exist. And we have even more bad news because we have to challenge our theories about CSF circulation, the distinction between adult and pediatric, and the distinction between acute, subacute, and chronic hydrocephalus. For example, I want to mention to you that right now we are basing our knowledge and our experience on the theory by Tiresias in the 19th century of the bulk flow. So CSF, according to this theory, is produced by the choroid plexus, flows through and out of the ventricular system, and then is reabsorbed through the subarachnoid villi at the convexity. This theory is based partially on the experiment by Walter Dandy, and in which he obstructed the aqueduct of a dog and noted an expansion of the ventricular system. And later on, Bering, in 1962, observed that ventricular enlargement will occur only if there is a difference in pressure between the cerebrospinal fluid and the brain. So according to the bulk flow theory, we elaborated also other classifications. For example, this is the classification elaborated by Dandy of non-communicating and communicating hydrocephalus. I won't go into detail, just to let you know that the non-communicating hydrocephalus is distal. The blockage is distal to the foramina of Luschka and Magendie. And we elaborated also the classification of obstructive and non-obstructive hydrocephalus, being the non-obstructive hydrocephalus caused only by oversecretion, for example, due to a choroid plexus papilloma. Is that all? No. What would happen if you were told that our Cushing experiment was conducted only on one dog, and then we had unsuccessful attempts of scientists to reproduce the experimental results by Cushing. So I think that maybe, of course, we are not sure, maybe we are on the verge of a Copernican revolution. And you can see here that at the University of Zagreb, Professor Orskovic and Professor Klarica elaborated many papers challenging the classic idea of CSF circulation. We do not have time, of course, to go into details. This is just to let you know that maybe in the future we'll consider hydrocephalus as an interstitial pathology, and maybe the ventricular dilation is just the top of our iceberg. On the other hand, we are still considering shunting as a very simple procedure with just 2 catheters and 1 valve. And we still consider shunting as a minimally invasive surgery with almost no complications. But what happened? I will show you some clinical cases. For example, this is a young woman with clearly a slit ventricle syndrome who was admitted to our department in 2019 with headache. Of course, she had a malfunctioning of the system, and putting an EVD is simple. But what could we do after that? So we decided to do an ETV, and we decided to free the ventricular catheter. And you can see here in this very short video how distorted the normal anatomy and how confusing it can be. And you can see here this huge thalamic deep vein and how dangerous it could be to try to remove that catheter without before freeing with an endoscopic technique the catheter itself. So this is the result with the third ventriculostomy and maybe a shunt-free woman. And just to let you know that shifting from this picture to this picture took almost 4 months and 20 surgical procedures. But why? Why would a young neurosurgeon, a young neurologist, a young colleague be attracted by hydrocephalus? Hydrocephalus is commonly believed to be a simple subject for simple minds and left-handed surgeons. And I would like to show you at the end of my presentation that, in my opinion, hydrocephalus is a very complex subject for very smart guys and only for an experienced team. In fact, the problem with surgery is that it still carries risks, and the equilibrium for our patient can be a very unstable one. So I think that we should be committed to try to see further, just standing on the shoulder of the giants. And I think that we should be in the middle between the doer and the thinker. Maybe the surgeon sometimes identifies himself or herself with the doer, but really we should think about things. It's not only a problem of surgery. And to show you that this is really true life, I want to show you this paper by Pyatt, published in 2021, in which in the US in 2015 or 16, they had almost 50,000 index admission for hydrocephalus. And these 50,000 index admissions for hydrocephalus were not only children and infants. Adults and elders played a major role in this. So it is not a problem of the past, and it is not only a problem of children and infants. On the contrary. Now I will show you some clinical cases. For example, in this patient admitted with hydrocephalus to our neurosurgery unit, you can see here that we have clearly an intraventricular tumor confirmed by the MRI. It was a lymphoma. Then we did an endoscopic biopsy, and we left in place one EVD for 1 day, and the patient was then successfully discharged on post-op 2. We could have a colloid cyst. This is a 30-year-old female admitted on a Sunday afternoon to our hospital with, I could say, an intimidating hydrocephalus. She immediately underwent an MRI. Then we removed endoscopically the cyst, and this is a long-term follow-up of her, free of complications. This is another case admitted with an acute hydrocephalus to our department with a third posterior third ventricle lesion and acute hydrocephalus. So we decided to put an EVD. We performed the MRI, and we decided to do an ETV with the biopsy. Unfortunately, the biopsy was not diagnostic. And in the next 3 months, the lesion almost doubled. So we decided to remove the lesion. Unfortunately, the lady who is actually the mother of a colleague of us demonstrated a high-grade glioma. But this is the 18 months follow-up, and for now, she is doing quite well. Of course, we can also treat endoscopically monolateral foramen of Monro stenosis. And more rarely, we can treat a bilateral foramen of Monro stenosis. Like in this case, for example, this is the control MRI. And even more rarely, we can treat a bilateral foramen of Monro stenosis with an aqueductal stenosis. And you can see this is the case of a 65-year-old man who did an MRI 3 years before for cephalalgia, and then was admitted to our department 3 years later with this acute hydrocephalus. You can see that it was clearly very, very worse than it was 3 years before. And you can notice now the aqueductal stenosis with an high riding basilar artery. This is the presentation of the short video with the foramen of Monro stenosis. We coagulated the membrane, then we dilated gently the foramen of Monro, and we did the third ventriculostomy. And this is again the long-term follow-up of this man who is actually doing very well. And this is another, I think, quite interesting case of a young lady who had a previous MRI for other reasons. She was suspected to have multiple sclerosis, which was not verified. And you couldn't notice anything, I think, here. No ventricular dilation, but she was admitted 2 years later to our department with acute hydrocephalus. We took the time of having an MRI, and the aqueductal stenosis, the bulging of the third ventricle floor is quite evident, and this is the ventriculostomy. We could have also other cases. For example, this is a case of a fourth ventricle outlet obstruction in a young Down patient. We put an EVD because she was comatose. Then we had an MRI. clearly showing the signs of the fourth ventricle outlet obstruction. And again, this is a long-term follow-up of her. And last but not least, this is another, I think, quite interesting case, also with acute hydrocephalus admitted to our department. Then we decided to do an MRI, even if the patient was not cooperant, you know. And the neuroradiologist noted this hyperintensity at the OBEX and decided to do even fine with the MRI. So this is clearly a fourth ventricle outlet obstruction, but this is taking the path of the OBEX, resulting in syringomyelia. And you can see here that we treated her with third ventriculostomy and even with a nice result on the syringomyelia. I want to spend a few words on IMPH. IMPH was described with this thesis by Professor Kim in 1964. And in the end, they had not the concept of ventricular dilation without an increased intracranial pressure. This is why he described the special clinical problem of symptomatic hydrocephalus with normal CSF pressure. This is strange nowadays, but we should go back and read the paper to understand. In fact, he uses the Pascal law in order to describe how the ventricular enlargement can have a pressure kept constant. And you can see here, this is in the original paper, that the pressure is constant when inflating the balloon. The pressure rises up when you have to win the elastic force on the balloon, but then the pressure drops down again. This is what is thought could have happened in their cases. And this hydraulic press by Professor Hakim is based again on the bulk flow theory. Maybe in the future we will have to revise it. So everything seems quite clear. We have an Hakim triad symptoms with ventriculomegaly. Maybe we have a positive TAP test shunt, but many things need really to be evaluated. We have several answers to give to our patients. We need to know is VPS, VAS, LP shunt is more effective than others, which valve should we use, which entry point, and we should complete with the follow-up of our patients. In 2018, we did this systematic review and meta-analysis. I won't go through details, but VP shunt, VA shunt, and LP shunt doesn't seem to have a very different outcome and doesn't seem to have different kind in terms of rates of complication. But of course, this is an open field, and we are still questioning if we can do better than that. There are also skeptics. This paper was published in 2017 by Alberto Espe, and the chief of the journal commented, is there even such a thing as idiopathic normal pressure, hydrocephalus? So they had a very elaborate system, but only 32% of the 32% of the patients had a sustained response at 36 months. So they concluded that many of these patients really had a secondary disorder. So I think there's really a need for a change of mindset. And I think that this change of mindset should come also by neurosurgeon. We found some time too time demanding hydrocephalus and maybe a little bit unexciting. But we should always keep in mind that first we should do no harm, and that we also need a very thorough multidisciplinary discussion, a tailored project plus patient's expectation, and we should use a very long-term follow-up. This is the diagram in which at the center is the patient, their caregivers, and at the borders is the multidisciplinary team. And this is why in May 2015, almost 10 years now, we had a team of professionals. We built a project on hydrocephalus. It was prospective, it was prognostic, and it was meant to be for the patient, pro-patient. So we decided to call it ProHydro. And this ProHydro team is quite elaborated. You see that we have an outpatient evaluation, candidates to MRI, and then inpatient program. And we have very long discussion on these cases. And you can see in the end that not 1/3 of them goes to VP shunt, and even the inpatient program is quite elaborated. So we are not really committed to surgery. We are committed to study this patient. This is Julia, our neurologist who published this paper in 2019. This is Paolo Mantovani. We correlated the callosal angle with clinical symptoms. We also said that maybe anterior callosal angle was an interesting marker for IMPH. And we were able to show also that the narrower the ACA, the worse the gait. Of course, we are studying in detail this patient with rigidity, bradykinesia. Also, the gait impairment is studied in detail. And you see that we use the time up and go, the 18-meter walking test, the number of steps, the correction in the tandem walking, and the Tinetti assessment. And we used also instrumented quantitative motor performances pre 24 hours after TAP test, 72 hours after TAP test, and at the 6 months follow-up. And you can see here in this nice diagram that our patient, after 24 hours, did improve a little bit, most after 72 hours, and this is the 6 months follow-up through the inertial sensor-based assessment. This is David, and this is these are our two engineers, and of course even neuropsychology is very important in this patient. And I will go very quickly to the conclusions. I think that hydrocephalus is a very, very interesting topic. We definitely need young people. We definitely need new energies and resources. I think that our role is to be true mentors to these people. For example, I found Uwe as a true mentor, and I will always thank him for that. And I also think that we should try to shift the paradigm, from cure hydrocephalus to take care of people with hydrocephalus. I want to remember you that in September we will be in Japan, in Nagoya, from 13 to 16. And I want to thank you very much on behalf of all the ProHydro team here in Bologna. And last but not least, going back to the statue in the very beginning, let's always remember that hope gives life. And thank you very much.
Well, Thank you very much, Giorgio, for this wonderful talk. I think there were a lot of insights, but of course there will be a lot of questions. I just want to ask also the audience if they have any questions, just put it on the Q&A button. But I just want to start a bit from the beginning with the obstructive hydrocephalus cases, what you show. Sometimes we do have, for instance, a colloid cyst, or we have aqueductal stenosis with a complete obstruction of the aqueduct. But we don't have an hydrocephalus sometimes. And this raises a problem. For instance, with a colloid cyst, if there is no hydrocephalus, but the colloid cyst is larger than the foramen of Monroe, how should we proceed? Should we just say, go home if you have some symptoms, come back? There are some reports of sudden death, of course, in those patients. So what is your recommendation how to proceed with those patients having a complete obstruction but no hydrocephalus?
Well, of course, these cases they challenge the backflow theory, of course. But I must say that, of course, we have also radiological signs of the inside content of the colloid cyst. If we think that it is very dense and full of protein, let's say, we tend, and if the patient experience cephalalgia, then we tend to treat this kind of patients if we see that there's a complete obstruction, because we fear a sudden neurological deterioration. I must say that during the years I have found colloid cyst to be effectively treated endoscopically. We had only minor deficits after the operation. So in these cases, if there's a dense content of protein, if the foramen of Monroe is completely obstructed, and if the patient experiences cephalalgia, I think we are prone to treat that kind of patients.
Thank you. There is one question from Ben.
Yes, thank you so much for these inspiring lectures. And
thank you.
I'm always puzzled when talking about the CSF dynamics and also hydrocephalus, because nowadays it's getting more complicated. Not only you have the backflow theory, but also other, for example, the gout lymphatic pathway, making things more complicated. So I've several questions. So in your opinions, what is if you have to decide, let's say a trial or experiment to understand the hydrocephalus, so what is the most important thing that you want to do in this study to understand the CSF flow to improve the current backflow theory? My second question is about for the role of ETV in the normal pressure hydrocephalus. Do you have any experience doing this, and do you think it will work? And I also have one last question. It's about the term external hydrocephalus. So so sometimes, for example, after interventions or people having a subdural effusion with hydrocephalus, how would you manage them? This is my question, and thank you so much.
Thank you, Ben. I think very, very interesting and very, very dense questions here. So, well, I think that you just said the right words. I feel in between. I feel in between. I think that we cannot think of the backflow theory as the right theory right now. I think that we need something else. Something else, of course, is coming out. I want to mention to you that we are now studying lymphatics with the MRI. So I would go back to the papers by, for example, but there are many authors on that, by Per Christian Eide.
Yes.
So I think that the glymphatic theory, I think it is here to stay. I think that it is here to stay. I mean, it will change our mindset. I will also, I think that in the future, we will also we will be able to understand much more the role of the proteomics in the CSF. For example, think of the role of the aquaporins. Aquaporins 4, I think that in the future, we will read more and more about the role of the aquaporins in Hydrocephalus. And last but not least, also the role of the cilia. We usually don't think of the ependyma, but why do we have cilia there? Why? We still do not know. We still do not understand very well. There's a world underneath the surface, and it is for that I mean we need to be really passionate about this, because there's still a lots of things we do not understand. And for example, these three things, I think that they will help us explain CSF blockage and then hydrocephalus in the future. Regarding ETV in IMPH, ETV-IMPH, we have only one prospective and randomized clinical trial. It was published, I think, from Fernando Pinto in 2014. So they didn't found that ETV was successful in treating IMPH patients. There were also some Italian papers by Gangemi in the past, but it was pre-MRI. So I think they had good results in ETV in these IMPH patients, but nowadays I don't think we would classify that kind of patient with the MRI as IMPH patients. So I don't think we can consider ETV as a first choice for an IMPH patient. And then external hydrocephalus. I would say that we need we need another webinar. So please, Professor Krista Curti, take note of this.
Okay.
Let's discuss this again in the future.
We'll definitely take note of that.
There is Joe, a question from Joe, please.
Hi, I'm Sam Joey from Malaysia. Thank you so much, Prof. Jojo. That was a very interesting lecture, and I like how you titled your lecture, because it is definitely a very big topic and there are a lot of things we still need to learn about it. I have two burning questions. I think lately we sometimes, like for myself, I find a lot of cases in which we see hypodensity around the ventricles, which can sometimes be, I would say, misinterpreted as periventricular lucency. But sometimes it can just be microangiopathic changes. So let's say if for yourself, how do you differentiate between these two? If let's say the hydrocephalus is not very obvious and it can still be ventriculomegaly, do you have any tips in differentiating ventriculomegaly and hydrocephalus with these areas of hypodensity around the ventricles? So that's my first question. My second question would be, sometimes we do lumbar punctures to test the opening pressure and to see whether patients improve. However, there are also reports and opinions in which the lumbar puncture pressures are not reflective of the intracranial pressures. So what's your opinion on that? Thanks.
Thank you very much. I think that these are really Good questions, and I must admit that I have no definite answer for you. I think that you should consider as a first thing that we have a clear demonstration that even vascular comorbid patient, Joyce, they can have a successful improvement after shunt surgery if they have ventriculomegaly. So I don't think that a vascular hypodensity should be an exclusion criteria from shunt surgery. Of course, I think that it is important to differentiate. And actually, I briefly showed you that, for example, here in Bologna, we test every patient with the 3T MRI. Of course, the 3T MRI gives you with spectrum analysis and DTI and diffusion and perfusion, gives you a lot of data in determining if you have a vascular sufferance, for example, or if this is a true hyperdensity due to lucency of a transependymal diffusion of the CSF. But in the end, I think that this is a question we should try to answer in the next years, because right now we don't have a definite answer. We know that these patients tend to improve almost equally to the non-vascular patients, but of course we need more studies even on that. And then the second question about ICP in the ventricular and the lumbar puncture. Well, I think you are right. You are right again. But I don't think we should test ICP putting a ventricular catheter if we do not think the patient is undergoing an operation for hydrocephalus. So I think we should base our decision on the lumbar puncture. They may not be the same, okay, this is right, but I would say that there's no actually a clear-cut explanation to put a ventricular catheter or a subdural catheter only to test ICP if the problem is hydrocephalus.
Well, thank you very much. I just have another question. You are from a very academic setting in your department. It's really fantastic. However, we do know that normal pressure hydrocephalus is so often. So we think about up to 3 or even 4% of the elderly people. So that's enormous mass of patients who have normal pressure hydrocephalus. So you cannot do with all those patients this really academic examination. Otherwise, you probably would lose and would not give the patients the benefit of a shunt. So what would you say is essentially needed for testing a patient with suspected normal pressure hydrocephalus than to shunt him? So not from the academic point of view, but from the real day clinic. What would you say? What is really necessary? It's just large ventricles and a positive spinal tap test?
Well, thank you very much, Uwe. I do not consider myself as a very academic person. I am a country neurosurgeon. No, I am a country neurosurgeon. So I am both ends in the field, you know. So I like very much your question. Well, I think that for example, can be used to give a positive predictive value to our shunt surgery. But I think that in order to treat a patient, if we have a clear-cut MRI with clear signs of hydrocephalus, like the dash sign, a very narrow callosal angle, and we are in presence of a classic clinical triad, we have 90-95% shunting that patient without any additional test of a successful surgery. Of course, I also think that in order to shunt a patient without any additional testing, you should be only in a very experienced hydrocephalus center.
Okay, thank you very much. There is one question from the Q&A buttons. It's, do you do shunts in hydrocephalus? What kind of shunts do you use? And I would say it a little bit more concrete. Probably it's also meant in normal pressure hydrocephalus, what valve should you use? What pressure setting, what special kind of valve is recommended from your point of view?
Thank you again for this question. I think that there are many things, as I told you before, that we don't know for sure. So again, I don't have a definite answer. I can tell you my experience. My experience is that I started with VP shunting because I was used to do it with a programmable valve and with an anti-siphon device. So we know that programmable valves and anti-siphon devices, for the current being time in the literature, they give us the best option treatment. So I think that when possible, you should treat an IMPH patient with a programmable device and an anti-siphon device. Regarding VP, VA, or LP shunts, again, I don't know really. I can tell you again my experience. I shifted, you know that, from VP shunting to VA shunting. This is because I had lots of migration of the peritoneal catheter. I was not really very happy with that. I do not have a general surgeon in my hospital. I don't have laparoscopy, for example. Then with the VA shunting, I am able to do this procedure under local anesthesia, and I didn't experience, of course, any malpositioning of the distal catheter. So that would be my choice.
Thank you very much. And I just would say, do we still have some time for questions?
We can have 5 minutes.
Okay, thank you very much. We know from patients with normal pressure hydrocephalus what we shunt. They have very good results. It was shown up to 90%, but we also know in longer period of time, there is a decrease of the good outcome in those patients. Of course, they're getting elder, but often they are deteriorating more rapidly than the age could explain it. So we know after about 3, 4, 5 years, a large percentage of shunted patients are getting worse and regaining the Hakim triad or some of the symptoms. So what is your procedure? You just down-regulate the shunt just to get a better drainage. And for my experience, it works very well in many patients. Or you just start again from looking if there's some shunt problem or some other new problems. What is your recommendation and how you handle those patients?
Well, thanks again. I would say that these patients, they're elderly. Being elderly doesn't mean that you have to be sick, but that does imply that you can have comorbidities with you. So I think that here a multidisciplinary team is crucial. You have to refer the patient to the multidisciplinary team, have a geriatrician and a neurologist with you. And of course, this is why I said that we should need to put a programmable valve, because I think that reprogramming the setting of the valve is a very quick, very easy, very fast, very economic procedure. So you are not losing time, you are not wasting money on that. It's worth to do it. But I also think that before that, you should exclude a malfunctioning of the system.
Okay, thank you very much. Well, we have a lot of how would you say, a lot of people, they just discussing if normal pressure hydrocephalus even exists, or if they say it still exists, but shunt surgery is so dangerous. So I also get several times patients which were not referred, although they had a normal pressure hydrocephalus, an approved normal pressure hydrocephalus, because the treating doctor said, "Oh, shunt surgery is too dangerous." So I think it's very important to know that normal pressure hydrocephalus is a progressive disease. We know this, and shunt surgery is very beneficial. But still, we have this problem, and I think this is very important just to say all to the audience, even if there are some problems, that we should treat those patients. Of course, we have to learn, and as you said, it's not an easy surgery. We just have to do everything to reduce all the complications. But we can do it, and we can learn from complications, from our own complications, from others, just to reduce it in the future. And of course, as you said, we have to learn quite a lot of the pathophysiology, because very often we still treat a black box somehow. But we have to learn, we have to study, but we know already that it's a very beneficial treatment, and I think we should give this to our patients, this progress, what we have done in the last 30 years or 40 years. So, Giorgio, I want to thank you very much for your really intriguing lecture. I think everybody learned a lot. And I'm very much looking forward to future talks of you and to learn more from you. Thank you very much.
Thank you. Thank you. It was really a pleasure to be here with you.
And now I will give to the organizer to go on. Thank you very much.
Well, thank you very much, Prof. Giorgio Palandri and Prof. Uwe Keller, for this wonderful session. We learned a lot. You put your best to compile everything in under 30 minutes. Extremely grateful. So I'd like to mention to our viewers that this has been broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 350 people who have logged in across different channels from all over the world. So we're extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. So now I'll move on to the second session. So I'll hand this podium over to our second chair, Professor Hitoshi Fukuda, to say a short introduction and invite our second speaker, Professor Chuan Chen. Prof. Fukuda.
It is our pleasure to invite Professor Dr. Chuan Chen from China. And it is also my pleasure to talk about this topic, because it is also my great interest, and I'm really focusing on this topic after the widespread use of flow diverter on the ICA aneurysm. So today he's going to talk about trapping with bypass in the treatment of complex ICA aneurysms. So please start your presentation, Dr. Chuan Chen.
Okay, thank you so much for the introduction from Professor Fukuda, and arigatou gozaimashita. Okay, hello, professors. And first of all, it's my great honor to join the ACNS online course, and I'm very grateful for the invitation from Professor Xubin and Professor Raya. Firstly, I have to apologize that I didn't post my city location in the worldwide world map as the last professor do, and I think it will be helpful for everyone to know where my city located. Actually, Guangzhou is the one of the largest city in China, and only secondary to Beijing and Shanghai. Okay, and I am Dr. Chen Chuan from the Department of Neurosurgery, the third affiliated hospital of Shenyang University in the city of Guangzhou, just in the south part of China. And my specialty is the treatment of cerebrovascular diseases through the open surgery, the interventional surgery, or the hybrid surgeries. My topic today is the efficacy of interventional trapping combined with high flow bypass in the treatment of complex ICA aneurysms. In recent years, the hybrid surgical techniques in our center are mostly used in the treatment of ischemic cerebrovascular diseases, such as the multimodal recanalization for chronic occlusion of ICA or CCA. Nevertheless, with the popularization of FD devices, the hybrid surgery, which is as a traditional method, is used less and less in aneurysms, actually. However, the hybrid surgery, which is able to completely isolate the aneurysm from the brain circulation, is still currently a reliable method in treating complex ICA aneurysms. And there are indeed some useful ideas worth sharing with you. Okay, the topic today is how to use the hybrid surgery to treat complex ICA aneurysms. First of all, we have to figure out which kind of aneurysms belong to these complex ones. Actually, complex ICA aneurysm refer to those aneurysms which are difficult to operate, have relatively high complication rates or recurrence rates. They're mainly divided into the following four types. First, the large and giant size aneurysm, blood blister type aneurysm, fusiform aneurysm, and the last one, traumatic pseudoaneurysms. Generally speaking, in our center, the blood blister type aneurysms are always small in size, and the parent artery are always good. So in our center, we always use FD devices to treat the blood blister type aneurysms. But for the other three types, we have already used the hybrid surgical techniques to treat them. Okay, for most complex ICA aneurysms, we still recommend to use the FD devices to treat them. Because after all, the endovascular treatment is relatively less invasive and very simple to operate with even good long-term efficacy. However, there are situations where we have to choose the hybrid surgeries, such as for those cases where it is difficult to advance to the distal end of the parent artery. Second, for those patients who are intolerant to dual antiplatelet treatment for at least half a year, or patients with any bleeding disorders. The third, for the patient who has a severe elongation, tortuosity, or a stenosis of the parent artery proximal to the aneurysm. And the last one, for the relapsed cases who previously had undertaken the interventional treatment of the same complex aneurysms. Okay, these are the four situations where we have to choose the hybrid surgeries in our center. And for most neurosurgeons, I think they are familiar with the procedures of the hybrid surgery, so I will not explain them in detail here. Nevertheless, I have created a schematic drawing showing the general principle of the hybrid surgical techniques. In our center, they mainly divided into 3 types. In all these 3 types of techniques or strategies, we occlude the proximal ICA with ligations, coils, or detachable balloons. But the ECIC reconstruction strategies are different. Firstly, in the first type, which is shown on the left of the slide, we use the RAG, which is radial artery graft, or SVG, saphenous vein graft, to connect the ECA and M2 segment, where the ECA works as a donor artery. And in the second type, just in the middle of the screen, we use the RNG or SVG to connect STA trunk and M2 segment of MCA, where the STA trunk is the donor artery. And the last one, the third one, is well-known double barrel STA MCA bypass. Okay, the 3 types of in the 3 types of strategies, they provide different blood flow rates, have different procedures, and carries different risks. So how should we choose? Through practice, we have explored a flowchart on how to choose an appropriate strategy for complex aneurysms in our center, which is shown on the previous slide. And firstly, the BOT is routinely performed before surgery. And if the result is positive, means that the ECIC reconstruction plays a role in the blood flow substitution. Then we will choose ECA to MCA bypass because it can provide the highest blood flow rate. And whether we will choose RAG or SVG as the interpositional graft depends on the result of the Allen's test. Here, I will recommend to use the RAG as the first choice because it is more resistant to the twisting, kinking, or pressure. And okay, if the BOT is the result of BOT is negative, means the reconstruction plays a role in the blood flow supplement. Then we will choose STA to MCA bypass. Okay, if the both STA branches were well developed, we will choose double barrel STA MCA bypass, which is in the middle of the screen. And if not, we will choose STA trunk to MCA bypass. And whether to choose RAG or SVG depends on the result of Allen's test. Okay, the overall principle of this flowchart is to choose a relatively less invasive method to solve the patient's problem. And in our center, the double barrel STA MCA bypass is the most popular option actually, because it's less invasive and no need to have another incision in the neck or in the arm, and no need to dissect the sylvian fissure. Before we get started to introduce 3 typical cases, I have another question to discuss with you. It is necessary to occlude the distal end of parent artery. Actually, we have answered this question in our published paper in 2017. That is unnecessary to do so because just a small amount of the retrograde blood flow does not affect the gradual formation of thrombi in the aneurysm dome. And additionally, not occluding the distal end of the parent artery is also beneficial for preserving the blood flow to the anterior choroidal artery. And in that article, we collected 4 cases to support our point of view, and we are glad to see that there are other scholars, which is shown on the right, share the same view with us. Okay, let's move on to the case illustration. The first case I'm going to share with you is a routinely successful case, and it was a giant aneurysm originating from the C6 to C7 segment of ICA. And the cerebral blood perfusion in the ipsilateral hemisphere was severely impaired, just shown on the CTP images. And the DSA images, we firstly tried the interventional method, but we found it's very hard to find the outflow of the aneurysm. So we failed to treat this huge aneurysm with interventional method, then we have to choose the hybrid surgeries. Okay, the BOT result is negative. We can clearly see the compensatory blood flow from the ACOM artery and PCOM artery. And according to the flow chart we just mentioned earlier, we chose to perform a double barrel ACTA-MCA bypass. The two branches of ACTA were anastomosed to the M4 branches on the surface of the temporal lobe and the frontal lobe, respectively. And after confirming the patency of the bypass, we occluded the ICA, the proximal ICA, with coils. And you may notice that the occlusion size in the ICA is really high, just close, very close to the inflow of the aneurysm. So why did we do so? Actually, we had a lesson here, and I will talk about it later. Okay, and then we used the same method to occlude the PCOM artery where the blood flow also supply the aneurysm. And then after the all the antegrade blood flow were blocked, the blood flow from the bypass grafts got stronger, and the compensatory blood flow from the ACOM artery also increased. And the last picture is a photo of the patient just 7 days after surgery. And we can see from the picture that he had put on his own clothes and was ready to be discharged. No neurological dysfunction was detected. Okay, let's have an analysis of the imaging data of the patients just before surgery and during the follow-up period. Okay, we can get a lot of illuminating information here. And first, let's look at the first column, and it's the CTA images. And here we can see the process of gradual formation of thrombi in the aneurysm dome, which also supports our point of view in the article published in 2017 that the distal end should not be necessarily occluded, right? And in the second row, you can see that the impaired CTP was significantly improved after bypass was done. And the CT images 12 months after surgery looks a little bit different since it was taken by another CT machine, but that's okay. And then we need to look at the DSA images just in the third and the fourth and the fifth row together, columns together. And then we could find that the ACTA branch anastomosed to the frontal lobe gradually disappeared, while the ACTA branch anastomosed to the temporal lobe got much stronger over time, and the compensatory blood flow from the ACOM artery also increased. So this indicates that after the bypass, the brain circulation has the ability to self-regulate in the blood flow distribution, right? And if you look closely enough in the fifth column, you may see that the right A1 portion, which was elevated by the giant aneurysm before surgery, descended gradually just within 1 year. So this we can conclude that the interventional trapping with high flow bypass techniques can also reduce the tension of the aneurysm and alleviate the occupying effect of the giant aneurysm, right? It is interesting. And in the sixth column, after blocking the blood flow from the PCOM artery, there were still a small amount of blood flow directly running into the aneurysm, but it gradually disappeared over time. Okay, the last picture is the patient 1 year after surgery, and no neurological dysfunction was detected, and the blood flow rate of the bypass graft was measured by Doppler to be greater than 70 milliliter per minute. That's great, right? Okay, this was a routinely successful case, and most of the complex ICA aneurysms in our center can get a good prognosis as he has. But sometimes, especially in the early years when we didn't have enough experience, we may encounter some unexpected situation where we were forced to perform a repeated repeated surgery. So let's move on to the two defective cases. Okay, the first one. This was also a giant aneurysm, unruptured giant aneurysm, originated from the C6 to 7 segment of ICA. And from the DSA image, we can find that there was a severe stenosis in the proximal ICA. Okay, this is also the reason why we finally choose to perform a hybrid surgery instead of FD devices. Since the STA branches were not well developed, we have to choose STA trunk to RAG to M2 segment bypass. Okay, the radial artery was harvested from the forearm, and one end was anastomosed to the M2 segment, and the other end was anastomosed to the STA trunk. After the anastomosis was done, and after confirming the patency of the bypass, the proximal ICA was occluded by 2 detachable balloons, and the post-operative CTA images shows a good anastomosis, good patency of the anastomosis, and a good CTP result. Okay, and unfortunately, on day 8 after surgery, the patient suddenly developed new infarction symptoms, the hemiparesis on the left side. So the CT images immediately indicates a new infarction in both the temporal lobe and the frontal lobe. And especially in the CTA images, there was severe stenosis of the RAG right near to the anastomosis was detected, which was confirmed by the following DSA images. So this is weird, right? It happens strangely. How could a stenosis occur on a newly harvested RA just 8 days after surgery? So all this was a vasospasm, but there was no subarachnoid hemorrhage was detected in the CT images. So in order to find the answer, we carefully review the surgery video. Finally, we found that this was not a stenosis, but a twist on the RAG. So we can see from the picture that the RAG was too long, right? Was too long, and there was a lack of soft tissue around to support it. So we decided to use interventional method to solve this problem. Firstly, we tried a small balloon to dilate in the twist site. Firstly, we did not dare to cause this anastomosis because it's just 8 days after surgery. We are afraid of rupture or bleeding. And let's see the effect. Not good, even worse. Okay, and we have to dilate it again. This time we decided to use a bigger balloon, and we decided to cause this anastomosis in order to get better effects. Okay, it's a little bit better. It's better, but can we just stop now, or can we just leave it at that? Can we? We don't think so. We didn't think so, because this was a twist, not a spasm. If you leave it at that, with the pulsation of the artery, the radial artery grafts may get twisted again in the near future. So we decided to deploy a stent to support it at the twist site. Let's see the effect. Perfect, right? Perfect. So here was a picture of the patient 5 years after surgery. You could see that the neurological dysfunction recovered gradually, and the blood flow rate of the radial artery grafts was measured to be greater than 90 millimeters per minute. And what is interesting that this case won first prize in the case presentation contest that year. And we can learn, what we can learn from this case is that when harvest the radial artery as a bypass grafts, it should not be too long. And then we should retain some kind of soft tissue around to support it to avoid twisting or kicking or something like that. Okay, this is the first defective case. And the next case is unruptured pseudoaneurysm in the ICA, which was caused by a car accident. The patient was a prison guard, and in the DSA images, we could see that there was a severe elongation and stenosis in the proximal ICA. So this was the reason why we finally chose to perform a hybrid surgery instead of FD devices. And the BOT test was negative, and then we can clearly see the compensatory blood flow from the ACOM artery and the PCOM artery. And since the STA branches were not well developed, we have to choose the STA trunk to RAG to M2 bypass instead. And the radial artery was harvested from the forearm, and the bypass was performed fluently and successfully. And after confirming the patency of the bypass, the proximal ICA was occluded by 2 detachable balloons, which we can see in the picture. And after surgery, the pseudoaneurysm disappeared, but there was a small amount of blood flow in the patellar artery, which was indicated by the yellow arrowheads. At that time, we thought that would be a small amount of retrograde blood flow, and it should gradually disappear over time. But the follow-up DSA images just 1 year after surgery surprised us a lot. Let's see. There was obviously the antegrade blood flow, and which came from the ascending pharyngeal artery. And the aneurysm relapsed, but the relapse aneurysm was not too big, not too large. And what should we do in this situation? And generally speaking, we have to choose these aneurysms through the approach from ACOM artery or PCOM artery, since the proximal ICA was already occluded. But this kind of surgery was kind of complicated and carries additional risks. So we finally decided to wait and watch for 1 more year, follow up for 1 more year and see. Okay, after 1 year, 1 more year, it gets worse. Okay, because the blood flow from the ascending pharyngeal artery is antegrade, so the blood flow is more obvious and even run directly into the MCA. So at that time, we thought actions must be taken to solve this problem. And instead of approaching the aneurysm from ACOM artery or PCOM artery, we decided to use the same guiding catheter. The reason is simple, that we don't want to puncture another femoral artery or radial artery. So firstly, we tried the ascending pharyngeal artery, but we failed due to the tortuosity of the ascending pharyngeal artery. We cannot get we could not get to the aneurysm from this approach, and therefore the treatment from the RAG approach, which was established by ourselves 2 years ago, seemed to be the only choice for us. Okay, let's see the effects. Let's see the procedure. Actually, no similar cases had been reported before we did. So we were kind of nervous actually, but we thought it would be safe because this anastomosis had been established for 2 years already, and it should be stable. And under the guiding of the roadmap, we slowly and carefully advanced the microcatheter to through the RAG, and finally we got to the aneurysm. And there was an interesting point. Please look at 2 pictures with the time on them. And when we passed through the RAG, the RAG suddenly became a spasm-like change. So I thought this change will severely affect the brain blood supply. So we quickly put back the microcatheter, and to our astonishment, the shape of the RAG returned back to normal just within 1 minute. So we inferred that it was not a spasm, just a mechanical traction from the microcatheter. And this is also called denervation, which will happen just after the radial artery harvested from the forearm. Okay, next we could see from the picture that the aneurysm was coiled, and in order to avoid another episode of recurrence, we also occluded the parallel artery along with the aneurysm, and the post-operative CTA images showed a good anastomosis and good bypass, and the CTP was also good. The last picture is the patient 1 week after surgery and then 5 years after surgery, and no neurological dysfunction was detected, and the bypass blood flow rate was measured to be greater than 80 milliliter per minute. And from this case, we could learn that if we decide to occlude the ICA, the proximal ICA, so we should do it as close to the inflow of the aneurysm as possible, because this the ECA system could be the source of relapse. And this is also the reason why in the first successful case, remember, we occlude the proximal ICA in such a high place. Yeah, we learned a lesson from this case. And we also had another publication summarizing our experience in treating the complex ICA aneurysm with hybrid surgeries. Okay, after three cases, I've got 5 tips for you. Okay, the first one, if possible, choose double barrel STA MCA bypass first, since it's less invasive, and no need to have another incision in the neck or in the forearm, and no need to dissect the sylvian fissure. Second, in order to avoid the aneurysm relapse, try to occlude the ICA at the C4 segment or even more distal. Third, the distal end of pulmonary artery should not be necessarily occluded, since just a small amount of retrograde blood flow does not affect the gradual formation of thrombi in the aneurysm dome. And fourth, retreating while bypass graft is feasible, which can be proved by our successful cases just mentioned above. And the fifth, consider the interventional therapy as the first choice, since it's less invasive and relatively simple to operate, even have a good long-term efficacy. Okay, here comes the last slide of my presentation, and I just want to finish with this very, very much special case. And this was an iatrogenic ruptured pseudoaneurysm in the C4 segment of ICA, which was caused just in the middle of a nasal endoscopic surgery in another department. So it was an emergency case, which was different from the cases before. And at that time, the covered stent was not available in our center until 2020. So firstly, we tried coiling, and it didn't work. As a matter of course, because this was an pseudoaneurysm, and 3 days later, it ruptured again. So therefore, the interventional trapping combined with the high flow bypass seemed to be the only choice for us. And fortunately, the surgery went successfully, and the patient was saved. So the point I just want to emphasize through this case is that although most complex ICA aneurysm can be successfully treated with endovascular therapy, when encountering some special situations where the interventional method is not feasible, the hybrid surgery can be a backup plan to solve the patient's problem, even save patients' lives. So that's all for my sharing today, and Thank you thank you so much for having me, and thank you so much for listening. ありがとうございました。
Thank you, Professor Chen, and showing us a lot of the variety of your hybrid strategy for the intractable ICA aneurysms. And now we are open for question. And
as you told that the intervention is a better technique as compared to the operative thing, as you mentioned about those 5 things. So is it universal for all giant aneurysms, you want to say?
This is a question about the choices between the interventional therapy and open surgery or hybrid surgery. So in our center, mostly we use the less invasive method because we don't want to do any additional harm to the patient. So if the aneurysm is suitable for interventional surgery, we will no doubtfully choose the interventional method to treat the patient. But as I just mentioned in my PPT slides, that in some special cases, the interventional therapy is not feasible, such as the severe stenosis of parent artery, or we cannot get the distal end of the aneurysm, which means the outflow of the aneurysm, or a case like that. We cannot use, if we cannot perform interventional surgery, we will have to perform the hybrid surgery or open surgery. But for some aneurysms, maybe such as the MCA routine aneurysms, we will choose the open surgery first. But for the complex ICA aneurysms, which means the pseudoaneurysms of form, which cannot be operated by routine open surgery, then or it cannot be successfully treated with the FD devices, we will choose to perform a hybrid surgery.
Can I talk about this topic? Yes, actually, I understand what the Professor Matri and the Professor Chen said, and but I think for the parent artery occlusion of the intractable aneurysm, including fusiform dissecting, giant, we have to do it. The case by case. I don't want to stick to the interventional or procedure alone because sometimes the fusiform aneurysm involves perforators or I know some giant aneurysm is kind of like a thrombosis aneurysm. The wall and the thrombus is sometimes fed by the data vaginum from the ICA proximal. In such a case, intraluminal coiling doesn't make sense. In such a case, interventional trapping still results in the growth or the rupture of the aneurysm. In such a case, we have to clip the parent artery to stop, to block the vaginum growth of the aneurysm. So I understand what Professor Matria says, that in some giant aneurysm case, sometimes we have to put the clip proximal to the aneurysm. But I also understand that Professor Chen says that in most cases, trapping of the giant aneurysm result in the same result, even if it is trapped by coiling or the clipping. So that's my opinion. Okay, so next question is from Ben.
And
yes.
there's one more point that I want to add, Professor Fukuda.
Okay.
There's one point that I want to add. Yeah, in the fifth column, I just mentioned that we very worried about the huge or large aneurysm. So what is the end of this kind of disastrous disease? And in the fifth column, we can see that the A1 portion is gradually descended within 1 year. And that means the trapping and the bypass techniques are also beneficial for reducing the tension of the aneurysm and the occupying effect of the aneurysm. So if you occlude the ICA, high enough, you can get the same result as you do it in a clipping way. This is my opinion. Yeah, I'm very much agree with what Professor Fukuda just said. Yeah, that's true. Yeah.
Yeah, in this case, I appreciate your operation because you didn't you didn't just put the coil at the proximal, and you also use the PCOM pathway to block the distal or inflow, distal backflow from the ACN and bypass. So I think this is the key for success in this case. Yeah, this was a very
Yes,
difficult aneurysm.
Yeah, definitely. Yeah.
Okay. So Ben, another question.
Yes, thank you, Professor Chen, Span from Hong Kong, and thank you so much, and congratulations on your success in these complex aneurysm cases. And we have so much to learn from you. And question is, besides RAG, you mentioned that you also occasionally need to use the saphenous ring. So I would like to ask, can you share some techniques in preventing the twisting or thrombosis of the when using the saphenous ring? And also, the second question is about after your hybrid cases, what do you need to give an antiplatelet in your case? Can you share with me your regime in antiplatelet or anticoagulation?
Okay, those are interesting question and very key points to the case, to these cases. And for the first question is about the interpositional grafts, right? So how should we do something to avoid kicking or twisting? Actually, we seldomly in our center seldomly use SVG because SVG has the valves. So after valves, firstly you have to know the direction of these graphs. The firstly, and secondly is the wall of the SVG is really thin, so it's less resistant to the pressure. So if we can use the SVG, the RAG, we'll choose the RAG without no doubt. And if the Allen's test on both arms are positive, in that case, I will choose the SVG. We have to choose the SVG. So you asked me, is there any we can do to avoid twisting if we use the SVG? So we have to pay attention to the edema of the muscle, the temporal muscle, and also the craterotomy, the area of the craterotomy to avoid the pressure on the SVG. This is my point. And the second is the anticoagulation plan or antiplatelet plan, right? Yes. Actually, we use the aspirin. We use the aspirin at least 5 days before surgery and on the day of the surgery and lifelong time. This is our plan. Also the tartan as well. Yeah, just single antiplatelet therapy.
Can I ask one more question? For those with the in your cases as shown, those complex aneurysm case with a hybrid surgery, what is your post-operative blood pressure management? So how would you titrate the blood pressure after surgery?
You mean the management of blood pressure after surgery? Yeah. Actually, we this is really an interesting question. Like when we perform the CEA or VEA, we will lower the blood pressure by 20% at least to avoid the hemorrhage in the brain. This is common sense. But in this hybrid surgical techniques, actually, when we perform ECIC reconstruction, actually, we sometimes the procedure plays a role in the blood flow supplements or substitution. when substitution, we play a bypass and occlude ICA. So the blood flow to the brain maybe even less than before surgery, I think. So the management of blood flow, management of blood pressure is not as strict as we perform CEA or VEA. The same as to the STMCA bypass when the ECIC reconstruction plays a role in the blood flow supplement. So in this time, in the supplement situation, we will intentionally to lower the blood pressure then by 20% or so. Yeah, this our experience. This is not a definite answer, but it's our opinions on this. Yes.
Understood. Thank you so much and congratulations.
Thank you for asking. Very interesting.
Thank you very much.
Okay.
One question I would like to ask Prof is that in earlier days where even now this has been performed, when you harvest the STA, you harvest two branches when you connect one branch to the MCA and you use the other branch to put in a micro manometer catheter and you check the pressure difference when you occlude the ICA and when the ICA is patent. It should be up to the 60% of the MAP. Single artery is enough to perfuse the brain when the ICA is occluded. Okay, and this technique was used very often, even now used by Professor Katsumi Takizawa, whom we witnessed doing so many bypasses. And on the other hand, if this pressure does not come any near to the, like it's not up to 60% of MAP, then you go for a ECRM2 graft. And the problems about the twisting and all, you said that when you harvest, you draw a line over the RAG. You draw a straight line before harvesting, so that when you pass it from the neck to the cranium, it is straight and not twisted. And also the Shaker's technique of pressure distension, it has shown to decrease the post-operative vasospasm.
That's exactly what I wanted to say. The pressure distension technique and the skin marking pen before the using the radial artery graft, because you experience that twist of the interposition graft of the RAG, so you don't want to experience it again. So just use a skin marker.
Yes. So thank you very much. I think we can conclude this session. You can give your concluding remarks, Prof. Fukuda.
Okay. So thank you very much for your cooperation to this nice discussion with passion, and I really enjoyed that. And I was really impressed of the Dr. Chen's interventional technique through the bypass graft, and it was feasible. And okay, I will try it in the next time when I was in trouble.
Right.
Thank you very much, everybody, for joining.
Well, thank you very much. It was indeed a very interesting session. Wind this up officially on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both speakers of today, Prof. Giorgio Palantri and Prof. Chuan Chen, as well as the chairs, Prof. Uwe Keller and Prof. Hitoshi Fukuda, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 350 people who have logged in through all different channels in various parts of the world. Thank you, my dear co-hosts, Dr. Ben, Dr. Joy Sam, and Dr. Libun Singh for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.